Welcome everyone to today's program. I'm Heather Punke, editor of Becker's Infection Control and Clinical Quality. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at this time, but this email will not include the presentation. It is now my pleasure to introduce today's presenters. Shante Wilson is a consultant at Freed Associates who has worked on the shift from volume to value since the Affordable Care Act's inception. She has over a decade of experience helping both public and private healthcare organizations implement organizational changes to meet ACA goals, including meaningful use, physician quality reporting, and accountable care organizations. And we have Deborah Mathias, who is a consultant at Freed Associates. Prior to her position with Freed, Deborah was the president and CEO of her own consulting firm, Mathias Consulting and Research. Over the past 18 months, she has worked with health plans, nonprofit organizations, and healthcare institutions, developing strategies to address new payment methodologies and implementing population health systems. She also has experience leading acute care facilities at the executive level. In her career, Deborah has served as the executive vice president and COO for 2 different tertiary pediatric hospitals, with academic affiliations, and was the CEO for a for-profit community hospital. It is now my pleasure to turn the floor over to Shante to begin today's presentation.
Great, thank you so much, Heather. So today we're going to be talking about the volume to value shift and the implications on the clinical workforce. Next slide. So on our agenda today, we'll discuss the market forces driving the industry shift, what value-based is and how it's different from the traditional fee-for-service model. We'll highlight some examples of the value-based model, discuss impacts to your healthcare workforce and how you can help them prepare, go into a little more depth around examples, and answer any questions you have. Next slide, please. Thank you. So the market forces driving the industry trend are pretty simple. It's our demographics and costs. We all know we have an aging population, and the statistics are quite staggering. Some estimates show that 10,000 baby boomers turn 65 every day and will do so for the next 19 years. Just 6 short years ago, we had 40 million people over 65, and that's projected to rise to almost 80 million by 2050. Which is around 20% of our population. And this is a demographic that utilizes the most health care. So not only is this demographic growing, we're also living longer. Back in the 1970s, we were projected to live around 15 years past age 65. And in 2010, that increased to around 19 years. So we have a demographic that uses the most health care that's growing and using it for a longer period of time, which greatly impacts cost. I won't get into the specifics of costs, but you can see costs are continuing to rise, and it's already over 17% of our GDP. So what is our industry doing to deal with this trend? They're moving to value-based payments. Next slide. So before I get into value-based payments, I wanted to highlight the traditional volume-based or fee-for-service model. Under this model, providers were paid based on how many services, tests, or procedures they ordered. This model is not sustainable with the demographics that we just discussed. Additionally, it's a breeding ground for waste. The Institute of Medicine identifies that around 20 to 30% of U.S. healthcare spending was wasted on duplicative tests and unnecessary services. So CMS defined their triple aim goals of better care, smarter spending, and healthier people. And the value-based model supports these goals by incentivizing providers to hit quality targets, cost targets, as well as patient experience targets. On the quality side, this is really identifying how well you're caring for the patient. Targets include items such as preventative care. Have you taken your mammogram or received your flu shot? all the way to disease management, such as are you controlling blood pressure or managing diabetes. Cost targets under the value-based model are typically assessing providers against how they performed under the value-based model, under the volume-based model, or comparing them to their peers, such as regionally or nationally. And patient experience targets are emerging. This is really giving the patient a voice to ask, how well do you feel they were treated? Patients are provided surveys that ask them questions ranging from how well do you feel you were communicated to, was your pain controlled, to do you understand your discharge instructions? So under the value-based model, providers are not only incentivized to provide quality care, it's also publicized. There's a quote-unquote Yelp for physicians called Hospital Compare and Physician Compare, where you can go on and see how your providers or your hospitals are performing on many of the quality and patient experience targets. The shift from volume to value is also pretty aggressive as far as timeline is concerned. Next slide, please. So this is Medicare's timeline to value-based payments. In 2011, only 68% of payments were linked to quality, and they have a goal to increase that to 90% by 2018. Additionally, in 2011, there were no alternative payment models, such as accountable care organizations or patient-centered medical homes that Deborah will highlight briefly. And by 2018, they have a goal to increase that to 50%. So not only is Medicare's timeline aggressive, the commercial industry is also following. Many commercial insurers have identified they want to have at least 75% of their business linked to quality by 2020. So regardless of where your workforce sits, they will be impacted by this volume to value shift. And I'll turn it over to Deborah to highlight some of those value-based models.
Thank you, Shantae. I appreciate it. So the next slide, we can take a look at the kind of that sliding scale. So I'm pretty sure everyone who's on the conference today has heard about the new payment model to incentivize value and accountability. So for many years, we have been paying providers at the very lower end of our ascending scale fee for service. And pretty much we've come to understand in the United States that paying fee for service, so every time you do a test, admit a patient, or do a procedure, you get paid for your volume. And that the current shift is dramatically away from that model. So as you go up the scale from inpatient DRGs to bundled payments, there's a shift in risk from insurance companies, and that includes Medicare, Medicaid, and the commercial insurers, to the providers, since the belief is, and has been proven through a number of CMS studies, that providers drive costs. So the shift is in placing financial risk at the provider level instead of at the insurance level. And as you go up the scale, I mean, very few of us will probably be involved in an organization that takes on a fully insured product. That would be Kaiser at this point in time. But many of us are working with organizations, hospitals, physician providers that are deeply involved through their ACOs, accountable care organizations, in shared savings, global budgets, prepaid capitation. Those models have been around for quite a while. And in those models, the providers, hospitals, specialists, primary care, regardless, take on risk for that total cost of the patient's care. So that's something that's growing certainly across the nation and is very important in terms of being successful in caring for a population of patients. I did take a look back. I wanted to look at some of the characteristics of successful ACOs. And as you think about your workforce, you think about how care is organized either in your outpatient programs or in your acute facility. Some of the characteristics of a high-functioning ACO includes an organization that already manages and coordinates patient care. So it would be unusual for an organization to enter into an ACO if they didn't have some competency in managing and coordinating patient care. That they understand the financial risk associated with taking on total patient care costs. If you don't understand that you're going to be taking on all of the inpatient, outpatient, and in some cases post-acute care costs, it can be very challenging. And a third area that we always talk a lot about, but the ability to measure what those costs are and how you're performing against them. So again, being able to track all the costs and all the care sites that patients are receiving care. It can be quite a stressor on your workforce because it's different from what they're used to. 10 years ago, under fee-for-service, it was really physician demand or, basically driving costs. Now we expect most care to be delivered under a team-based model. So you might have a care coordinator, you might have a medical assistant, and each of them have a role in delivering the care to the patient, whether inpatient, outpatient, or post-acute. So basically just wanted to get an understanding that as we move up that scale, as it ascends, the risk to the provider organizations, which we're all part of, really increases rather substantially. Next slide. So this is just a picture, sorry it's a little hard to read, of where ACOs are most dominant across the United States. So it's pretty clear to see that they're coastal, meaning that a lot of the ACOs formulate and grow where we have population density. So LA is a big area, parts of Arizona, the East Coast, Texas, and there are now about 23 million people assigned to ACOs across the United States. About 7.8 million are Medicare, which I think would take some people by surprise. That means the overwhelming majority of people who are assigned to ACOs, who are enrolled in ACOs, are either in Medicaid or the commercial payer market, which, I think a lot of people think it's really Medicare, but it really has grown across all of the payer markets. And ACOs obviously are, even though we have ACOs in all 50 states, you can see on a county-by-county basis, there are areas of the United States where there are absolutely no ACOs. So again, a lot of it does have to do with population density. And right now, under Medicare, there are three main ACO models, and that's Medicare Shared Savings. Most organizations are talking about that because, a certain percent of their patients are Medicare. The Pioneer ACO model, which has been around the longest, and then the Next Generation ACO model. So again, all of the ACOs have, that are really successful, really have taken on, they look at value, they understand what is the difference between volume and value. They put a particular focus on primary care. There has to be an entry point for patients to receive care in a timely manner. Access has to be pretty wide open. Patients have to be able to access their primary care provider pretty easily, part of their integrated medical home. And then, of course, the whole concept of care coordination across the entire continuum, and then strong physician leadership is very important. But again, it just shows from this slide that, ACO enrollment is going to grow across the United States, and based on what Shantae said, the push is to get 90% of fee-for-service Medicare enrollees in some type of ACO in about 5 years. So Shantae, I'll turn the presentation back to you.
Great, thank you so much, Deborah. Can we go to the next slide, please? Thank you. So as Deborah identified, there are impacts to your healthcare workforce, but there are also a lot of opportunities in the shift to value-based. There's an opportunity to move to team-based care, where your care team works at the top of their license to support the patient. And this team includes your nurses, your medical assistants, your pharmacists, social workers, and others. Deborah mentioned this before, but coordinating care across the continuum is critical to meet your value-based goals. Your workforce has the opportunity to support the patients as they move outside the walls of your offices to post-acute care providers, including your skilled nursing facilities, your long-term care hospitals, your home health agencies, or other specialists and providers. Technology is also an opportunity. Access to health continues to be an issue, so your organization and your workforce has the opportunity to offer virtual visits or telehealth that can help support your patients' needs. Another opportunity for your workforce is including the social determinants of health as part of your care plans. We all know health happens outside the hospital walls and physician offices. And CMS announced they're investing over $150 million in accountable health communities, where providers and social services work together to meet the patient's full needs And this can include anything from connecting a patient to transportation or housing services. So although volume to value impacts your clinical workforce, there are lots of opportunities. So how do you prepare them? Next slide. So many of your clinical leaders may be focused on assessing some of your quality benchmarks against some of the upcoming quality programs, such as the merit-based payment incentive program, or even some of the alternative payment models that Deborah discussed. Equally important is preparing your workforce. As this chevron shows, you can do a current state assessment, identify your future state goals, and develop an implementation plan. For your current state assessment, you want to understand your workforce's current skill set, review your staffing models, as well as your workflows. Some specific questions you may want to think about when you're doing this current state assessment are, have you reduced any duplicative processes to drive out waste? Many organizations are using lean processes to help them do that. And then, do you have the collaboration skills to implement and engage with clinical teams across the care continuum? Many resources are used to the teams that they currently work with, and sometimes the soft skills are forgotten in training and professional development programs. So that's one of the skills you want to ensure that your team has and review if they have that ability in your current state assessment. Deborah talked about the importance of quality metrics. So you want to also understand if your team has the ability to measure and optimize meeting those targets. For the staffing model, you want to see if your team is implementing team-based care, if they have the right staffing model to support that. And lastly, you want to make sure that your workflow is optimized to meet cost and quality targets. So once you understand your current state, you want to work with your leaders to define your future state goals. This can be anything from additional certifications for your workforce to standardizing workflows across your system. In the value-based models, they are constantly emerging and changing, so having an ongoing training and professional development program can help support your workforce as those changes are implemented. So once you have your current and future state assessment done and goals defined, you can develop an implementation plan to address those gaps with a defined schedule, scope, and budget, and a strong project manager to help push those items through. There are also some key strategies that can help your workforce. Next slide. So governance is a key strategy as the shift to value-based is a change. So having leadership support at the top and a strong governance structure to address any risk issues or barriers as they arise will help ensure you meet your goals. Provider engagement is also very important. Identify a physician champion that can help push the message through the organization and gain buy-in from your workforce as these changes are different than many of the existing processes they're using. Patient engagement is really at the heart of the value-based model. As you're optimizing your workflows, you want to ensure the patient is communicated to and any workflow changes address any of your patient's needs. On the infrastructure side, I really can't say enough about the infrastructure. The value-based programs require a lot of reporting, so you want to ensure that you have the technology to be able to support those reporting requirements. You also want to have actionable analytics internally, which is you want to have information that can identify any opportunities for improvement, whether that's meeting quality targets, cost targets, patient experience targets, or internal targets that you've identified that you want to be able to identify those along the way. We all know communication is key, and I'd suggest including in your infrastructure a strong communication manager to define a communication plan with an identified cascade of communications to define stakeholders, because people are going to be asking questions, they want to know what's going on, so having that strong plan in place can help you prevent any miscommunications or misunderstandings in the organization. Another key component of your infrastructure is your contracting team. Many of these value-based contracts have terms and references that need to either be negotiated or defined internally. So have a strong contracting team in place. And have fun. This is a change, and change is always hard, but celebrate those milestones that you guys achieve. So really, there are a lot of opportunities with the shift to value-based, and understanding where your workforce is currently, developing a strong implementation plan, and utilizing some of these key strategies can help set your workforce up for success. So with that, I'll turn it over to Deborah to walk through some specific examples, and then we'll answer any questions you have.
Great, thank you, Shantae. So I'm going to give you an example of 3 different models of how we're seeing volume to value transitions and vice versa. One of the probably more interesting in this example 1, redesign of the medical practice, is the recent investment by CMS in the Transforming Clinical Practice Initiative. It's one of the largest federal investments uniquely designed to help clinicians in the practice setting. So rather starting, at the healthcare system or at the payer level, this is really a peer-to-peer collaborative approach where in 2014, the federal government came up with this practice transition formation concept, and they started to work with organizations across the United States to really promote practice transformation at the primary care level and really at the specialty care level. So this is where mentors and coaches will actually come into the practice and begin to help them transition their practice. They help them focus on coordinating care. So when they refer a patient to a specialist, the patient doesn't just drop off their radar, that they actually understand that the patient went there, received the care that they expected, what the results were. So a lot of that is technology, that is also communication. And they've established community-based health teams to support chronic care management. And this is a lot of thinking that we're seeing. So patients who have issues or problems that are really socially based or have some chronicity where there's a social or a community program available, they'll actually start to connect those individuals. So I worked with a large health system and the Alzheimer's Association, and what we did is we connected the support system of the Alzheimer's Association to the family members, and they had a fantastic response. So rather than the health system trying to develop a support program for the families of newly diagnosed Alzheimer's patients, they actually went to the Alzheimer's Association. So it was a wonderful collaborative effort. And again, like I said, this is bringing, change to value down to the clinical practice level. There are practices of 1, 2, 3, 4 providers. And if they're not practicing in the acute care setting very often, then some of this information or some of this transition may bypass them. So it's a real opportunity to change healthcare practice, healthcare management, and how we treat patients right at the practice level. Next slide, I'll just give you a high-level overview of 2 of the transformation networks. So the one that I'm most familiar with is the Practice Transformation Network, and this is really about 39 national and regional healthcare collaboratives, and basically they receive fairly significant grants from the federal government to reach down into private practices, group practices, health systems, et cetera, and to really help. They've got a goal of transforming about 140,000 clinicians over the next three years into these kind of new patient care, patient-focused value entities. And they help them change they use peer-to-peer coaching. They have peer groups within communities. They actually bring the service transformation down to the clinical practice level. And they coach physicians and they coach the staff on developing certain competencies. And I won't go through the whole list of them. I have the list of about 14 different things that they do. They do help them use electronic health records to track patients. They help them coordinate care and work with their family members. They monitor high-risk patients. That's a huge issue, and a major focus right now is that patients with significant chronic conditions or have conditions that lead to readmissions, high number of emergency room visits, they have, much more focus on those patients than maybe kind of the 40-year-old patient that just comes in for their annual visit. So it's a real transformation on how the practice really tracks and cares for individual patients. And then the practice transformation networks, there's about 8 of them in the United States, and it's from, let me give you a couple. The American Board of Family Medicine, there are 100,000 physicians that are members in this board, and they expect to recruit about 25,000 practices and help them go through this transformation effort. So their goal, again, is to help them use their memberships to transition the practices into much more of a value-based entity. The other participants are the American College of Emergency Physicians, American College of Physicians, American College of Radiology, and the American Medical Association. So again, a very different collaborative, peer-to-peer approach to changing and mentoring practice change. So I think on that, next slide. Probably the most dramatic change in healthcare reimbursement, and really a very, very significant shift in how certain hospitals in certain geographic areas called MSAs are going to be paid for patients who have lower joint replacements. So it's hip and knee replacements. And basically, for the very first time, CMS has said in these specific geographical areas, if you are going to provide a lower joint extremity replacement in a fee-for-service Medicare patient, you're going to be responsible for all of the care delivered at admission and 90 days post-discharge. So that's the bundled payment, that's the episode of care. But that is something that Medicare has never done before. It's never actually demanded that the acute care provider manage the care for this entire patient population for up to 90 days. So if a patient is discharged from the hospital and they go home, you'll need to make sure that that's a decision that you help make, that you involve the family, that you know that the patient went home, that they continue to receive care on a regular basis if they need it. Most of the patients will have to go to some type of rehab. That's an important part of them not ending up in a SNF, back in your emergency room. And if the patient is readmitted for a complication for the same diagnosis, then that care, that episode is included in. The hospital will not receive any additional reimbursement or compensation for that care. So I think it's just such a significant change and very different for our acute care system. The targets, how much you actually get reimbursed for, let's say, a hip replacement, has already been set by Medicare, and it's based on a historical or 3-year retrospective of total cost. So if you have a hospital located in Los Angeles and you use the same 10 post-acute care providers, SNFs, IRFs, et cetera, that cost of care has already been determined, and that target price has already been provided to your acute care provider. So I think that the important takeaway from this is really, I think, the most aggressive move on the part of Medicare to really say that the acute care system is responsible for the total cost of care and the outcomes for every patient that gets a hip or knee replacement. And it's been a unique experience. I helped implement this in California and Nevada. And I think a lot of the hospitals were taken aback about the amount of work it took to actually get it done. From an HR perspective, it's very important that you look at your care coordination department, that you talk to your discharge planners, that you look at your utilization review department, and are they really looking at patients from a long-term, in our world, 90-day perspective, and do they have methodologies, techniques, and tools to make that determination? So should a patient be going home, home? Do they have family support? Do they have some type of transportation, mobility, et cetera, to get to and from appointments? So it's a very different look at patients as they leave our acute care facilities that we're actually going to be responsible for. Next slide. So one of the things I did with a group of organized hospitals is we looked at 2 phases of getting ready for CJR. And obviously CJR started April 1st. So we really started to ask them, what should you be doing to assess your readiness for being paid for an entire episode of care? So we asked them if they really did understand the roles and the responsibilities of each of the departments making discharge decisions. Do you know the difference in the role between your discharge planners and utilization review department? Do you have a functional assessment, some type of tool like LACE or MPAC, that you really understand a patient's functional capabilities prior to admission, during admission, and what are your expectations when they leave the organization? So we saw that that was missing in a lot of organizations. And we also wanted to know who was making, were the orthopedic surgeons or was it hospitals that are involved in the discharge decision making? So we found that a lot of physicians have strong preferences for some facilities, but when we looked at the quality outcomes, we didn't see that they were there. So there were some recommendations around physician education and selection of post-acute care providers. So it's very important that you understand and really can assess your capabilities. Obviously, EHR capabilities are extremely important because you have to be able to upload some of the functional assessment information and risk scores. Make sure you understand basically where how the patients are doing and how they're going to perform in one of these settings. The other thing that we really encourage, and I'm sure your organizations, if you're involved in one of these MSAs, has done this, but to really look at the quality of the current post-acute care system that you're using. So that right now you can get on SNFs and home health agencies. You cannot get it on IRF. But there's a whole database available through Medicare on basically the same ratings that you're receiving, the star ratings, on the quality of care provided by post-acute care providers. And we highly recommend that if you have not run that data that you do it. And then the second phase of this is really implementing the CJR and post-acute care coordination system. So again, you know, have your case managers and your care coordinators really develop policies and procedures to establish care transitions. Is it evidence-based decision-making, and what evidence-based tools are you using to drive the first post-acute care selection? So post-acute care selection could be home health, home, or a SNF, but you really need some evidence-based tools to help you do that. We also felt that providing in-depth physician education was critical. A lot of times we found discharge decisions were made based on historical experience, habit, etc., and not on the outcomes and results, and actually patient satisfaction. Very important that we understand that when you're moving a patient from the acute to the post-acute setting. And then again, really helping staff learn to use functional assessment and risk tools. It's really helps you determine that level of care. It's kind of mysterious sometimes to staff. Would a patient do better at home with home health, or would they be better with a 5-day stay in a SNF? And there are some tools to help you make that decision. And then obviously, the biggest change for acute care providers is tracking patients and managing patients through the post-acute care continuum. And again, that takes staff that is trained, knowledgeable, and capable of understanding how to follow patients. Sometimes it's telephonically, sometimes it's with a home health provider contract, and sometimes it's with your own care management team. So again, we really felt that that was an important part of a learning change for the organizations. And last but not least is most organizations, most acute care facilities have never met with the post-acute care providers where they've historically been sending patients. So what we really encouraged was the acute providers to actually meet with and generate cooperative agreements. These are not referral contracts, but these are agreements for sharing information about patients. So quite a bit different than how we've managed patients historically, and I think it's, at least in some cases, at least with some DRGs and episodes, this could be the future of reimbursement for acute care facilities. It's been an exciting engagement that I went through, and I think that those of you who are in these environments certainly are getting a taste of the change in reimbursement. So that's the two examples really that we're going to give about, you know, volume to value reimbursement. And Shantae, I didn't know if you wanted to go ahead and wrap it up.
Sure. Thank you so much, Deborah. So this is our list of resources. Feel free to please check out our Freed Associates website. There are a lot of white papers and information about the shift from volume to value. Deborah and I's information is listed here. If you have questions, feel free to send us an email. And then a lot of the resources we discussed, from a lot of the CMS initiatives to the Health and Human Services Department, are listed here for resources. And with that, I will turn it back over to our moderator.
Great. Thank you, Shantae and Deborah, for that informative and enjoyable presentation. We will now begin the Q&A portion of the webinar. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll attempt to answer as many questions as we can today. To start, here's one that Deborah can address. Pretty simple. What does MSA mean?
Oh, thanks. That's a metropolitan service area. It's a geographical description that the government uses.
Got it. Makes sense. Okay, thanks, Deborah. The next question here is, if in the value payment model financial risk shifts from insurance to providers, will the authority to determine medical necessity also shift from insurance to providers? Deborah, could you address that one?
Could you repeat that again? I'm sorry, and I don't see the question. Anyway, if you could go ahead and repeat it.
Sure.
Oh.
So if in the value payment model, financial risk shifts from insurance to providers, will the authority to determine medical necessity also shift from insurance to providers?
It does in some cases already, and it really is based on the relationship between the insurer, i.e. Medicare in most cases, and the provider, but that is kind of on a case-by-case basis. But I suspect that will become, I think providers will become more comfortable with that concept over time.
Okay, great. That makes sense. The next question would be, where does correct coding and good documentation fit in under the shift from volume to value? And Shantae, could you address that one?
Sure, that is a great question. So as an industry, we shifted to ICD-10 last year from ICD-9, and that additional documentation provides additional specifications around DRGs, which highly supports the shift to value-based. Many of the value-based quality metrics are based on HEDIS metrics or the National Quality Forum metrics, and CMS has gone through a process recently to try to consolidate the many quality metrics out there. So there are now ACO core metrics out there, and good documentation supports you meeting your quality targets. Many of the value-based programs, you receive an incentive based on meeting your cost targets, but you also have to meet your quality targets, and good documentation can help support you meeting those targets.
Great, thank you, Shantae. The next question is, how important do you feel staff retention is in maintaining a high-performing organization? Patient focus, good in working care teams, strong payer relationships, etc.
That for me?
Address that one? Sorry. Yes. Shantae, you could address it.
Sure. So that's definitely a good question. Staff retention is critical. It's actually quite interesting. One of the projects that I worked on, because the shift to value-based is becoming so big now, trying to recruit and retain care coordinators is difficult. There are more opportunities out there than there are actually staff to fill it. So if you have good care coordinators, you want to ensure that they are involved in the process with the shift. They are at the heart of coordinating care across the continuum, so you want to ensure that any workflows that you have are supported by your care coordinators, and that you have a good staff retention program in place in your organization. So care coordinators are key, but it's also your technology resources. There are a lot of technical impacts with the value to volume shift, so you want to have good resources that can support your systems and a lot of the analytics that you're going to need to answer questions like, how are we doing?
Great, thank you, Shantae. The next question is, are hospitals better positioned in CJR if they receive prepayment versus post-payment reimbursement? Deborah, could you address that one?
Yeah, that is a great question. And this is what is such a challenge with CJR because it's retrospective payment. So because you're paying for all of the care that is being provided in the post-acute environment, and it's up to 90 days, so it takes Medicare about another 90 days to collect all of that data and information and then send it back to the hospital, to the acute care provider. So actually what you're really seeing is a delayed retrospective payment. So unfortunately in your first year, and that's why there isn't any downside in the first year of CJR in terms of your compensation. So if the hospital spends more than the target price for each of the CJR patients, for the first year, you will not be penalized. The second year, there's a gradual increase where you would be, your reimbursement would decrease by 5%, 10%, 15%. But because this is including post-acute care, you're receiving a very delayed notification on what your reimbursement is going to be because of the 90-day data collection period. So if that patient was in a discharge to a SNF and then they went home, but unfortunately because of complications they came back to the hospital, were readmitted, and discharged to a SNF again, all of those costs will be included in your episode payment.
Okay, thank you, Deborah. This next question is also for Deborah. How are the CJR participants receiving data from CMS on their target prices and their performance? What is the frequency of that data receipt?
So every single CJR hospital by now should have received its target payment. So the study that I did for the Los Angeles facilities, all of them learned of their target price about early March. So they knew that currently, I'm going to just give an example, it's easier sometimes, and I'm sorry, I wish I would have put one up for you. So if generally for a hip replacement, your hospital was receiving $19,000 in reimbursement for that care, then they would be receiving a regional payment. So if the regional payment, let's say you guys ran a little bit high on your reimbursement for Medicare, and say the regional payment for the acute side was $17,000 and overall reimbursement for post-acute care was $5,000, so your reimbursement would be $24,000. If your run rate is under that, then you generate money. If your run rate is over that number, then you'll begin to lose money. So I hope that answered it. So unfortunately, it's a very retrospective reimbursement model because you have to wait till all of the charges for all of the care, post-acute and acute, are collected by CMS and then fed back to your organization. That's where you actually need to track and monitor the patients on a real-time basis yourself. So if a patient is going from your hospital to a post-acute care provider, you should know what those costs should be, estimating the total cost of care for each of the patients that you are discharging.
Great, thank you, Deborah. Next, we have a question for Shantae. Do you foresee a large shift from LTC facilities to in-home services as part of this initiative?
You know, that's a good question. I think it's starting to emerge. I don't know how long it will take, but definitely home health is, many organizations are figuring out ways to shift the patient there effectively. So I wouldn't say it would happen anytime in the near future, but what organizations need to do is really figure out how can they meet cost targets, what's the most cost-effective and quality-effective location for that patient. So it's really case-by-case basis, and depending on the region and the agreements that the hospitals have with the long-term care hospitals or home health agencies is really going to drive that. But I would say it definitely probably will shift more towards home health in the future because that may be more cost effective in some situations.
Great, thank you. This next question is also for Shantae. How are ACOs addressing the behavioral needs of patients with chronic diseases? Are they using any technology to help address patient issues?
That's a good question. I would say how they're addressing them now, there's definitely an opportunity to optimize that process. What I've seen is, especially on the commercial side, is the commercial plans are still delegated, the behavioral health activities. And what that really means is the case managers for the provider work with the case managers for the health plan to refer the patient to their behavioral health network. It's definitely an area to optimize in the near future. It's not where it needs to be now, and we know behavioral health is definitely part of the whole patient health, so it's not where it needs to be right now.
Okay, thank you. The next question will be for Deborah. Could you expand on the role of EHR Database for CJR?
You know, in my experience, it really depends upon which EHR you've implemented. So, for example, and I'm just going to use this as an example, I'm absolutely not promoting any system, is Epic has inside, built into it, it already has a functional assessment tool. You can buy those tools from a third party if you want to, but what it does is it allows you to track the patients across the continuum, but also allows you to do a basic functional assessment. So if you look at your existing EHR, you may already have some of the tools in it, but since we have not been responsible for tracking patients in the post-acute care environment, we may not have discovered that. There are also some really usable web-based tools that you can actually just layer on top of your existing EHR. So probably the most well-known is an organization called AMPAC that was created by Boston University. And they have truly a web-based system that can just actually be uploaded into your existing EHR. So you're not creating a paper-based system, which we all know won't work in the long term. So basically, there are some very good web-based tools that you can begin to expand on. But if you have some of the existing, you know, very well-developed EHR systems, you actually have some of those tools built in already.
Great, thank you, Deborah. Moving on to another question about ACOs for Shantae. Are ACOs investing in continuing medical education for their physicians and care teams?
Yeah, they are, and it's really organizational based. So it's not something that's required of any of the ACO programs, but again, to be successful and to meet those cost targets, organizations are investing to ensure that whatever their internal strategic goals are, that the stakeholders are aware of those, and they're also working to optimize their processes and procedures, which will ensure that the physicians are trained, the patients are communicated to. So it really goes back to each organization's own plan to implement the ACO program.
That makes sense. Thank you. We have another question for you, Shantae. Will the CMS patient star ratings affect how insurance companies pick healthcare providers?
You know, that's a good question. I think I saw an article recently that Covered California, which is our health insurance market, identify that they will be targeting high-performing organizations, including on the quality performance side. So I don't think it's a firm yes or no, but the stars are emerging as an item that patients, as all of us are patients, would obviously want to go to a high-performing organization, and I'm sure the insurers will follow that.
Got it. That makes sense. This next question maybe Deborah could address. In the CJR program, what happens if a patient decides to go to a very expensive SNF and runs the cost much higher? Does the acute care hospital get penalized for those overrun costs?
So the answer is yes. You do get penalized. You are not being penalized, but you are going to pay for those. So again, very significant shift on how you deliver care. As you start to talk to that patient, hopefully you have something called a joint camp, where patients come in prior to their joint replacement surgery and you begin your patient education process. Then, if your orthopedic surgeons aren't too excited about that idea, you certainly can start to talk to patients immediately after they're out of the OR. I hate to say that, but immediately, as soon as they're calm and comfortable and feeling well, then you actually need to start talking about their post-discharge plans. If you've done your job and really taken a good look at the SNFs and you've run the star ratings, you are not allowed to, because this is a voluntary program for patients, these patients are not enrolled in Medicare Advantage, you cannot direct them to a contracted provider. So what you can do, though, is share with them the CMS star ratings on the post-acute care providers. So but if they choose the more expensive SNF, they have a right to do that, and that is going to be what you paid for. So it's smart to begin your education prior to admission for the surgery, and also importantly is that you really do understand the quality of the post-acute care providers, and it is they really do have quite a few that are in the one-star one-star rating. Under CJR, you are not allowed to use a SNF that has lower than a 3-star rating.
Okay, great, thank you. This next question is for Shante. Do physician productivity compensation methods contradict the move to value-based care?
Can you repeat that question?
Sure, definitely. Sorry about that. The question is, do physician productivity compensation models contradict the move to value-based care?
That's a good question. What I've seen is that for organizations implementing the value-based programs, especially the shared savings, where if they meet the targets, they get 50% of those shared savings, is they work with their contracting team to actually detail out exactly how physicians will be compensated in their professional services agreement. So it's really specific to, again, each organization, and I know I keep saying that, and I think what I want to highlight is many of the value-based models do not prescribe too many things, which means it'll set the target saying you have to meet this quality target, you have to meet this cost target, but how you actually do that is up to the individual organization. So there's not too many prescribed activities, it's just you need to meet the target. So organizations are identifying, okay, internally, how do we want to organize ourselves to meet these targets? And physician compensation is one of those things as far as sharing the shared savings. And even within organizations, it may depend on if the physician is either contracted or an employee, and it may be different across the board depending on those contracts. So your contracting team is definitely a critical part of your infrastructure.
Great, thank you, Shante. This next question will be for Deborah. It is, in the CJR example, is the payment actually held for the 90 days you referred to, or is the reconciliation of the payment done retrospectively?
It's done. It's long in this first year as the system begins to accommodate the change. So, for example, what I understood from the last, I joined it's called a Levitt presentation, and with questions and answers. So in the first year, since there will be no downside or upside penalties for the acute care provider, you'll basically continue to get your normal reimbursement. So at the end of 9 months, they'll feel like they'll have level set the reimbursement methodology, and then it'll be reimbursed on a regular basis, when you submit. But again, it's going to be based on that target price. So eventually it'll normalize, but in the first 9 months, it's basically understood that you won't get a lot of data or feedback from CMS on how you're doing. So again, making sure that you are tracking your patients and estimating the total cost of care against your target payment. But after 9 months, it'll normalize and you'll begin to be reimbursed as you have been in Medicare. It still will be based on, that target price. So eventually, over time in 2017, 2018, if you're over at the end, because it's a reconciliation at the end of the year. So if you're well over what your target prices should have been cumulatively, you'll have a reduction in your reimbursement. If it's under, then you'll get an upside payment.
Great, thank you, Deborah. This next question is kind of simple. Could you repeat the name and spelling of the web-based program developed by Boston University?
Yes, AMPAC, A-M-P-A-C.
Perfect, thanks, Deborah. This next question will be for Shante. Is there a reason for CMS to have 3 types of ACOs, Shared Savings, Pioneer, and Next Gen? How are they different?
So that's a good question. I would say, one of the main differences is the risk. There are different tracks, meaning under like track 1, for example, the organization does not have risk, meaning if they do not meet the target, they do not have to pay CMS back. Versus 3, if you don't meet the target, you may have to pay CMS back. But if you do meet the target, you'll get a higher incentive than under the upside only model. So it's really, most organizations start with upside only risk, meaning that they're going to implement the ACO program, they're going to try it out, they're going to see how they perform, and then in future years, once they've optimized their internal processes, then they'll move to a downside risk where they get a higher incentive payment, but they may have to pay things back.
Okay, that makes sense. Thank you. The next question is for Deborah. Are the target prices different for high-risk patients than normal risk patients? And are they determined retrospectively?
So no, this is a cumulative product. Now there are patients are eliminated from the CRJ payment. So if this is a elderly patient and they break their hip from a fall, those traumatic kind of admissions are excluded. So that would be considered high risk. But if you're saying a patient that has multiple comorbidities, is 100 pounds overweight, has high blood pressure, diabetes, and other chronic conditions, if your surgeons and your organizations decide to operate on that patient, then that patient will be in your normal target price. So again, I mentioned something called Joint Camp. It's really good to apply some evidence-based criteria for joint replacement patients. So it might be best for that individual to lose 30 or 40 pounds. It might be best if you get their diabetes under control and their hypertension under better control. So patients obviously will do better and have a lot more success if they're preconditioned prior to surgery. So that's just some of the factors that need to be considered. Also, you should, if you haven't already, really ask your, run your data and find out where the majority of your fee-for-service Medicare patients, joint patients are discharged. Now, you may find that the majority of them are already going home and doing well and not being readmitted. But if you have a high percentage of your patients that are going to SNFs and or being readmitted to your hospital, then you have a pretty significant issue ahead of you.
All right, thank you so much, Deborah. And it looks like we are running out of time. So I want to thank Shantae and Deborah for the excellent presentation and for all of our audience members for participating today. We would look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.